Welcome everybody to today's podcast, the Asthma Spotlight podcast. And I'm delighted and really honored to be joined today by one of my heroes in asthma, and that's Professor Ricard Beasley, who's a professor of medicine in New Zealand. So hello, Richard, and welcome to this podcast episode.
Good evening, Mark, and it's a great pleasure to join you this evening.
Thanks. So can we start by you introducing yourself and telling us a bit about the work that you do?
Yes, so I'm Ricard Beasley, and I'm based in Wellington in New Zealand, and I'm currently Director of the Medical Research Institute of New Zealand. And I suppose I've been an asthma researcher for almost 40 years now, and for me, choosing asthma to devote my research career towards was really, it wasn't a hard decision because asthma is such a problem in New Zealand and internationally. And in terms of New Zealand, we had epidemics of asthma mortality at the time I was training. Asthma is a very common disease and it's got a very high burden. So it was the obvious choice for me as a respiratory physician in terms of undertaking clinical research was really to investigate ways in which we could reduce the burden of asthma, both in New Zealand and internationally.
Well, I remember so clearly, the first time I became aware of you was your publication in 1989, together with Stephen Holgate on asthma management plans, and how that really changed the way that we managed asthma. You highlighted that the use of peak flow was so valuable in helping people to adjust their treatment and modify the way that they were controlling their asthma. So why do you think there's been such a move away from the use of peak flow over the last 39, 40 years?
Yes, well, certainly we were of the view that peak flow was the optimal way in which to recognize the severity of your asthma and know when to seek medical review in a severe attack. And so the management plans we developed really gave two options. Patients could both look at the symptoms and interpret their symptoms, but also be guided by peak flow monitoring. And those were our initial plans. And it was really also based on the philosophy that it was really giving the patient the guidance to self-manage their asthma was the crucial thing, because the key factor in terms of a bad outcome in asthma and asthma attack was a patient not recognizing how severe their asthma was and delaying seeking medical review. So we developed this plan that gave patients the option of both symptoms and peak flow, and it was shown to be very effective in reducing risk. And I think somewhat to our surprise, the subsequent studies showed that you could essentially get a very similar result just by giving patients guidance relating to their symptoms, which didn't mean that some patients wouldn't benefit from peak flow monitoring as well. But in terms of sort of a universal plan for most patients, actually just following their symptoms, in particular how much of their reliever was taking, was likely to be adequate to guide them when to seek medical review.
Yeah, well, it certainly was a groundbreaking publication, which, as I say, was the first, and it also changed the way we managed asthma. And so I suppose that brings us on to two things, really. You've done some wonderful work in New Zealand and also had major influence internationally. And so could you start by summarizing the reason why asthma is so important in terms of public health and as a research priority in New Zealand at the moment?
Yes, so we really look at, it's a research priority for both historical and current reasons. Historically, we'd had epidemics of asthma deaths related to specific asthma treatments, an over-reliance on reliever therapy rather than focusing on preventive treatment. But I think more generally, asthma is a very common disease. I think 1 in 8 New Zealand school children and about 1 in 10 adults are receiving treatment for asthma. And it's still a very frequent cause of hospital admission. And although asthma deaths are now relatively uncommon, they're still devastating when they occur. So I think from both in terms of the prevalence, but also the morbidity and the risk with severe attacks, it remains one of the major health problems in New Zealand and also in many other countries, such as the United Kingdom.
Yeah, and as you say, asthma deaths are really devastating, and also many of them are found to be preventable, certainly in my experience in the UK, but maybe we'll talk about that a little bit later. And so you mentioned that people are finding that you're finding that people are able to use their symptoms to guide their treatment. And that brings us on to the main reason why I wanted you to join me today. And that was to talk about the new approach to asthma management. And you're probably aware that I'm a member of the Global Initiative for Asthma, GINA, and we published new groundbreaking recommendations in 2019 that everyone with asthma should be prescribed an inhaled corticosteroid, either regularly or as needed. So can you tell us a bit about what we mean by anti-inflammatory reliever treatment, and what's the background to the development of this treatment?
So anti-inflammatory reliever therapy is the use of a combination inhaler that has both an inhaled steroid or preventive drug as well as a reliever medication. And so that is used as a reliever either on its own or in addition to maintenance preventive treatment. And I think we've really come across this form of the strategy for treating asthma from a number of directions. And I think we're coming for it, first of all, due to recognizing the risks of using what we call a short-acting beta agonist, a reliever medication, commonly known as a blue inhaler for reliever. And we've been aware for, well over 50 years that there are not only that, although they are highly effective drugs in relieving the airflow obstruction that causes asthma symptoms, that they do have risks. And they do have risks in terms of their long-term use gradually increasing the severity of the patient's asthma, but also when overused in a severe attack, have risks in terms of increasing the risk of a bad outcome and in particular mortality on occasions. And so we've been aware of the risks of the over-reliance and overuse of the blue inhaler, the short-acting beta agonist reliever inhaler, for a long time. And it's been quite confronting, I think, to doctors to know you're prescribing a drug that not only has major benefits, but also has potential risks. And I think that it has been confronting, and it's only been acceptable as an approach on the basis that there was no alternative. So if we now go to another strand of evidence, and that is that we've known for a long time now that the inhaled corticosteroid drugs are very effective in turning off the asthma process. They have anti-inflammatory effects, and if used regularly, they can markedly reduce the risk of severe asthma and severe asthma attacks. But we really have a real problem there in that many, if not most, asthma patients over time become very infrequent in the way they use their inhaled steroid drugs. And many patients actually stop taking them altogether. And so we have this very effective form of treatment, but we have a real difficulty in actually having a system whereby patients can obtain the benefit from them. And so I think if we take those two strands together, the idea came forward that, well, perhaps if you put the inhaled steroid together with the reliever, you will then ensure the patients will receive some anti-inflammatory reliever inhaled corticosteroid therapy on most days, or certainly on the days in which they use their medication as a reliever. But also, I think the really clever thing is that you can titrate the dose of inhaled corticosteroid preventer drug by using the vehicle of the reliever, so that when patients' asthma gets worse and they actually need more preventer, they receive it because they're getting it with their reliever drug, which they're using more often. And so really the concept is very simple, and I personally find it very deeply disappointing that it took the respiratory community, including the pharmaceutical industry, so long to realize that this was such a simple and likely effective way of treating asthma, not only in terms of greater benefit to the patient, but reducing the risk of the otherwise standard simple blue reliever inhaler therapy.
I've been around a very long time, and in the early 80s, we had a product in the United Kingdom called Ventide, which is a combination of an inhaled corticosteroid with salbutamol, which is one of the short-acting blue reliever drugs that blue inhaler reliever drugs you were talking about. and that went out of fashion. I think it was intended for use with teenagers originally who were reluctant to take their medication regularly. And so the pharma industry have been aware of this idea for a long time, but it's taken a long time, as you say, for them to bring this to the market, following research which you and others have been involved in. And so you spoke about the risks of the regular use of the blue inhalers, the short-acting beta agonists. So could we start with the advantages of this anti-inflammatory reliever therapy, or so-called air therapy?
Yes. So I think the overwhelming advantage is that it reduces the risk of a severe attack of asthma. So if you have a patient who's simply on a short-acting beta agonist reliever blue inhaler, and you switch them across to a 2-in-1 combination inhaler that has an inhaled corticosteroid and the fast onset but long-acting beta agonist called formoterol, if you simply switch the patient across, you'll reduce their risk of a severe attack by over 50%. And that's a hugely effective form of therapy and a marked reduction in risk. And if you then go to the more severe end of the asthma spectrum, and you have a patient who has moderate or severe asthma and is on a maintenance, regular, scheduled preventive drug, and you simply switch them across from the blue inhaler to, once again, this 2-in-1 ICS formoterol reliever, you can reduce the risk of a severe attack by about 1/3. So the benefit applies across the spectrum of asthma severity in both adults and adolescents, although unfortunately we don't yet have sufficient data in terms of children.
So 50% reduction in severe attacks, which really means also a marked reduction in the risk of dying from asthma. And from your research, you've clearly shown that you do get a reduction in severe attacks. Now, why do you think this treatment is working to do that where the blue inhaler treatment was not?
Yeah. So I think the basic reason is that as a patient's asthma, as they develop a severe attack of asthma and the inflammation in the airways and the swelling becomes more severe, a patient needs a greater dose of their preventer inhaled corticosteroid. And because it's within the reliever inhalers, the patient takes more reliever inhaler, they're titrating upwards the required greater dose of inhaled corticosteroid. And there's often quite a window of opportunity of a number of days while this process is going on. And it gives the chance to actually reverse the asthma attack before it becomes so severe that you may require urgent medical care.
Okay, so we come back to a point that we were talking about earlier. By the time somebody's getting symptoms, their airflow is often obstructed quite significantly. And so do you think that the added use of peak flow might have any additional benefit in guiding people when to take the anti-inflammatory reliever treatment?
Well, I think one of the fortunate sort of feature of this way of treating a severe attack is that probably the increased use of the reliever is not only an effective way to titrate the dose of inhaled steroid, but it's actually the predictor of the requirement for more inhaled corticosteroid. Now, no one's really looked at whether the use of a peak flow within the system leads to greater benefit, but I think it really represents an alternative to peak flow by using the reliever use as not only as both a predictor of risk, but also the solution in terms of greater titration of treatment.
Of course, you did mention there are two kinds of anti-inflammatory reliever treatment. One is where somebody's using maintenance inhaled corticosteroid with a reliever, and then they use that same drug for relief, which we call MART, or maintenance and reliever treatment. And then there's the other kind where people are using the anti-inflammatory reliever treatment on demand or as needed. And so are there any disadvantages of this form of treatment compared to the old way of treating asthma, where somebody's asked to take their anti-inflammatory drug regularly?
I think perhaps putting that question around the other way, I think the advantage of it, you get the greatest benefit if you use it within the structure of a self-management plan. And that's quite strongly evidence-based, because the clinical trials that showed benefit actually used the self-management plans as part of the study protocol to implement this regimen. But I think the disadvantages, there are a number. The first is that there's an insufficient evidence base in children, and children have a really high burden of asthma, particularly in terms of hospital admissions. And so that is a priority for further research. We've got very limited evidence in terms of patients who have both asthma and COPD. And that is really an area that also requires further research. We also don't have sufficient evidence to use it in the emergency department setting, where salbutamol remains the preferred emergency treatment, either with a metered-dose inhaler and a spacer, or through a nebulizer. So I think the other disadvantage is that we have a limitation of products and devices. And so the use of a 2-in-1 inhaler can either be with an inhaled steroid and a fast onset and long-acting beta agonist, of which formoterol is the agent for that. And most of the evidence relates to this combination, particularly the budesonide-formoterol combination. The other more recent combination is the use of an inhaled steroid with a short-acting beta agonist, which is also fast onset, of which the inhaled corticosteroids salbutamol or albuterol in the States combination product, there was recent evidence for its benefit. And in fact, this product has recently been made available and approved by the FDA for use in the United States. So we really need more combinations to be tested, and then on the basis of that evidence with different devices made available, because it's likely over time that some patients may prefer or be best suited with one particular combination or the other.
Thank you. That's very clear. And it would be really good if we could persuade more healthcare professionals to change the way that they're managing asthma. And as you said, people are reluctant to change, especially after 40 years of using a particular way of managing asthma. In fact, more than 40 years of using the blue inhalers for relief.
Yeah, and I think that's an important point, Mark, in that I think entrenched clinical practice is a barrier to the use of this therapeutic regimen. And the barrier occurs at many levels. It occurs in terms of a doctor who's entrenched in their own personal clinical practice, patients who may prefer to stay on the blue inhaler as part of their treatment regimen. And in some jurisdictions, there may be limited access or availability, either because of regulatory approval or in terms of cost and availability. So there are a number of barriers to the implementation of this regimen.
Okay, so now I'm aware that you've done a lot of work in New Zealand to improve the way that asthma is managed. And so what are you doing at the moment that is changing the way that healthcare professionals and patients are managing their asthma?
Yeah, so in our New Zealand asthma guidelines for adolescents and adults, we made very clear recommendations, which were modelled on the GINA recommendations that you mentioned from 2019, that for New Zealand, we had the availability of the budesonide-formoterol combination 2-in-1 product as a reliever, and we followed the GINA recommendations that this was the preferred reliever across the spectrum of asthma severity for adults and adolescents. And we recommended that it was implemented through the implementation of the asthma self-management plan as the optimal way in which you could introduce this regimen. And we had a very intensive implementation translational program throughout New Zealand, primarily based in general practice, because in New Zealand, almost all asthmatic patients are the primary medical caregiver as a general practitioner. And we were intrigued to really follow up how extensive the implementation, how much implementation actually occurred. And so we did a follow-up 18 months after the guidelines were first promoted widely within New Zealand. And there was a dramatic uptake in terms of the use of the budesonide formoterol inhaler. And we've now followed up more recently at a further 12-month period out, where it is now the dominant form of treatment for asthma in New Zealand. And I think this has two important points. I mean, I think at a sort of a local level, I think it shows the very high standard of medical care in New Zealand from general practitioners, that they were very adept in changing their standard of clinical practice to adopt these evidence-based recommendations. But I think more widely, I think it has implications globally, and it shows that it is possible, despite entrenched practice, to actually adopt a major change in the approach to asthma based on very strong clinical evidence, and that both doctors and patients clearly accept and prefer this as a form of treatment. And we should perhaps not be surprised by this, because in some of the studies that we looked at what have been the patient's preferences, and in one of our studies, we asked the patients who used this anti-inflammatory reliever therapy regimen for 12 months in a clinical trial whether they preferred to stay on this treatment or go back to the traditional form of asthma management. And 90% of them said they preferred the anti-inflammatory reliever therapy regimen. And, I think we perhaps shouldn't be surprised by this, because if you're offered the choice of one 2-in-1 combination inhaler that you just take either as a reliever or as a maintenance and reliever treatment, or you have two separate inhalers and one you take as a reliever and one you have to take on a regular basis, even if you feel you don't need it, it's not surprising the choice that the asthmatic patients will take.
I'm very pleased to hear that you were able to get the healthcare professionals to adapt to the new evidence-based way of treating asthma. And from our experience in the United Kingdom, what I'd really like to know is how you were able to persuade the general practitioners, because in the UK, asthma is also primarily treated in primary care, but in the UK, it's moved more towards nurse management of asthma. And at the moment, much of the asthma is managed by people without any training in asthma.
Yeah.
So how did you persuade the doctors in particular to change the way that they managed asthma?
Yes, although there's shared care between doctors and nurses in New Zealand in terms of asthma care, the primary responsibility for asthma management in New Zealand is general practitioners. And they view asthma as a priority because we've had such terrible history of asthma in New Zealand, including the epidemics of asthma mortality related to the overuse of two specific blue inhalers. And so I think that you had a very well-educated and motivated workforce who, when the evidence became available that there was an alternative, that they were very comfortable in adopting this change to follow evidence-based medicine. And this was a national program, and so this was widely across widely across in terms of clinical practice in New Zealand.
Oh, well, it's a lesson for other countries, and particularly for the UK. So I'd like to move on now to talk a little bit about asthma deaths. You're probably aware that I've been involved first in the National Review of Asthma Deaths in the UK, and more recently over the last 4 or 5 years as expert witness in asthma death inquests, where mainly children have died from asthma. And the recurrent themes really are that there's a failure of doctors to recognize the severity of asthma as a disease, or the potential severity of asthma as a disease, and also not prescribing preventer or controller treatment. And we're still seeing many people being treated with excess short-acting beta agonists. And one of the children who died had 50 prescriptions for a blue inhaler in the year before she died. And so what are your views on asthma deaths at the moment? Why are we still seeing preventable deaths due to this disease worldwide, but probably more particularly in the UK nowadays?
So, I mean, when I read your report, which I think was so important internationally as such a contemporary snapshot of causation of death and asthma, what struck me was how similar your findings were to the mortality surveys that were done in both New Zealand and the United Kingdom and many other countries 40, 50 years ago. That in some respects things had not changed, that people were still dying for the same reason, as you mentioned. Lack of recognition that they were at risk in terms of their long-term management, inadequate use of maintenance inhaled corticosteroids, and this over-reliance of beta-agonist drugs and the severe attack with the delay that went with it. And so I think that really does give us a template by which to, in some respects, do a checklist in terms of the way we approach asthma management today. And I think, very clearly, those features that you mentioned and I repeated can be addressed by anti-inflammatory reliever therapy. The amount a patient uses can be a guide to the severity of their asthma long term. You can largely address, but not completely resolve the issue of non-compliance in terms of regular use of inhaled steroids and titrating the dose when a patient needs it. And through an asthma self-management plan that goes with the AIR strategy, you can provide guidance to a patient in terms of when to recognizing they're developing a severe attack and need medical review. So I think in some respects we've come a full circle from 40, 50 years ago, and we now have a very simple, practical strategy by which we can address these core features that put patients at risk of mortality.
That's a wonderful summary of how this treatment can really be effective. So we've spoken about a number of things, and is there anything that you wanted to add that we haven't discussed in terms of asthma management?
No, I mean, I think that the evidence relating to anti-inflammatory reliever therapy is perhaps the biggest paradigm shift that we've had in asthma over many decades. And I find it intriguing that in most other fields in clinical medicine, management is becoming more complicated, far more complex and difficult. And here we have asthma where it's actually becoming simpler and more practical. If I was to finish on any key messages, I think the challenge for healthcare professionals is actually really simple. That in these days of evidence-based medicine, if we believe in evidence-based medicine, we need to be aware of the evidence of the benefits and the reduction in risk with anti-inflammatory reliever therapy. But we need to not only be aware of the evidence, we need to know how to implement it in our clinical practice, which I think ideally is through a management plan, and we need to change our practice accordingly. And if practitioners do not follow this pathway, I think that really is confronting and challenging in terms of their own personal commitment to evidence-based medicine. I think for clinician researchers, I think we should not forget about children who have a real burden from asthma, or the elderly who have COPD as well. And we need some robust landmark randomized controlled trials to see if we can translate the current evidence and extend it to these other high-risk groups. And in terms of patients, I think the message is that this is a real breakthrough. And as I mentioned, for many, it may be considered the biggest paradigm shift we've had over recent decades. And I think, it may be you need to ask your doctor or your nurse whether you are suitable for this regimen. And if not, why not? So you can also obtain the benefits and the reduction in risk associated with it. So, I think in some respects we're well on the path to this becoming the standard approach in clinical practice globally, but we have further work to do.
That's a fantastic summary. Thank you so much. And I think your point that if you really believe in evidence-based medicine, why aren't you implementing the clear evidence that we've got in asthma. And I think Albert Einstein said something like, if you're expecting a new result, why do you keep doing the same thing over and over again? So thank you so much, Professor Richard Beasley. It's been an absolute pleasure and such an enlightening discussion. I've really enjoyed this half hour with you. Thank you so much for giving us your time.
Thank you very much, Mark. It's been a real pleasure. And in finishing, I'd like to acknowledge the wonderful work that you and your colleagues do with the GENA strategy, which I think has provided such a strong evidence-based recommendations by which we can practice medicine and asthma.
Thank you very much. I'll share that with my colleagues. I'm sure they'll be delighted to hear that.